I'm Richard Geer, Physician Chief of Surgical Oncology at Sarah Cannon. The surgical treatment options for breast cancer kind of started in the 1890s. There was a doctor named Halsted. Dr. Halsted, when he first diagnosed women, when he was asked to see them, the average size of the tumor is about 7 centimeters in size. Most of the women have positive nodes underneath their arms. So he came up with what's called the Halsted radical mastectomy. And that was pretty much in vogue for the next, almost 100 years. It was still being done. And then in the 70s, in the 60s, started to look at, gosh, there got to be some other ways we can treat these tumors. At the same time, the tumor size had gone from 7 centimeters to now less than 2 centimeters in size. So does the one size fit all? The answer to that is no. And so we've had 6 clinical trials, and it's probably breast cancer may be the single best thing that's been studied in medicine to date. It's have what's called level 1 evidence. And level 1 evidence is basically randomized clinical trials, taking women to the same thing, picking a card, one gets treated this way and one gets treated that way. And through these randomized trials, we've learned that basically there's really no difference if we treat women with mastectomy versus lumpectomy and radiation therapy. So the two have the same overall survival rate. There's no difference in overall survival, and the local recurrence rate is not significant between mastectomy and lumpectomy. Now, there's some factors that may go into decision about why you should have a mastectomy. It may be that you have a large tumor for a small-sized breast. It may be you're a very young patient with a very strong family history. It may be that you have a genetic marker called BRCA1 or 2 that really puts you over the edge, and really mastectomy is the primary consideration. But currently, as we look at both of these methods, I think that what we've learned is that patients can be treated extremely well with lumpectomy, and the advantage to that is that the patient still has their native breast. It still feels like their breast. Generally, we take out less lymph nodes now than we used to. We used to take out lymph nodes in everyone who had breast cancer. So you would take out 10 to 20 lymph nodes. This would leave you with edema of the arm. You could have pain, swelling, discomfort, a numb sensation on the underneath part of the arm. Now we've gone to sentinel lymph node biopsy, which is taking out 1, 2, or 3 lymph nodes, testing those, and this decreases that rate of pain, recurrent discomfort, as well as lymphedema. So we're decreasing what we're doing to patients, and so what we're trying to do is to go from treating everyone the same to individually treating them, but making sure we're doing the right treatment for the right patient at the right time in terms of where we go. The other advantage to lumpectomy is that we can now follow the breast. To me, we can follow it easier than we can mastectomy. One of the misconceptions about mastectomy is that when one woman feels that she has a mastectomy, they've removed the whole breast, she has no risk of developing breast recurrent disease again. Absolutely not true. We can remove as surgeons about probably anywhere from 95 to 97% of all breast tissue on a mastectomy, but there's still 3 to 5% of breast tissue that may remain. And when that remains, it has the ability to become malignant at some point in time. So again, if you go back to the original trials, there's no difference really in local recurrence rate between mastectomy and lumpectomy. So therefore, really the decision needs to be a more personal decision. Some women feel that they want to have it done because it's going to decrease their risk of problems in the future. Not really borne out by the science at this point in time. The other thing about lumpectomy is that if you do develop a recurrence, generally it's much more treatable than if you develop recurrence with mastectomy, which is much more difficult to treat in terms of where we are. So I think as you go through with your physician, your surgeon, about what's the best option, you have to look at a number of factors, and I think the first blink is that everyone goes, just take it off, I'm done, I want to be through, I don't want to have anything else done, and then I'm through. But it's a little more complex than that, and actually there's some really good data that lumpectomy actually may be the better choice for most women. One of the most important things that we can find for prognosis, your prognosis of breast cancer, is the status of your lymph nodes. And it gives us information, it changes your stage of your tumor, and it gives us information about how we should best treat you in terms of this. Now, the other thing that's changing currently in breast cancer, it probably has changed more in treatment in the last 5 to 10 years than any other disease out there. We're now using genetic markers. We're using other things like something called an Oncotype DX score, where we can look to see with your tumor if it is going to respond to chemotherapy or not, or the likelihood it's going to recur. And therefore, if it's a low likelihood it's going to recur, oftentimes we don't even give chemotherapy to those patients. So we're now looking specifically at how the tumor marks to determine exactly what's best for you. So we know that lumpectomy, mastectomy is fairly equivalent. Now we're looking to further hone it down to see if you have certain markers where the best spot to go is. So in order to stage the tumor, we have to know the tumor size, the tumor type, as well as the lymph node status. In order to do lymph node status, again, we've gone from taking out 10 to 15 lymph nodes in every woman that I saw to now only taking 1 to 2 nodes out of women and testing those. If those are negative, we don't do any other nodes. If they're positive, we've even now decided some patients with positive lymph nodes under the arm that's a small volume, we don't even need to take the 10 to 15 nodes out. There's a recent study out looking at that. So we're even doing less surgery these days. But some patients with positive nodes will result in axillary node dissection. So instead of taking lymph nodes out of 100% of women, we're doing probably less than 20% of women are undergoing axillary dissection at this point in time. And the importance of that is as we get the stage, we can then determine about what's the next best step to treat you. When you get a pathology report back, there's 2 types of pathology reports. The first one will be when they first diagnose you, you'll get back the tumor type. It'll just be a core biopsy during an ultrasound-guided core biopsy in radiology or in your physician's office. It'll come back with the tumor type, whether it's a duct cell carcinoma or lobular. Again, the ducts are the ducts carrying the milk production from the lobules, which produce the milk, towards the nipple. So what type of tumor it is. It also will come back with receptor status on it. And receptors are important because things that are estrogen and progesterone receptor positive tumors generally grow because of estrogen. And the nice thing about that is we can target that and give anti-estrogen drugs to block that along the way. There's other things called HER2/neu status that we now have a drug called Herceptin that can be beneficial with that. And then to know, the other thing we know, when all those are negative, it's called a triple negative tumor, and that is a much more aggressive tumor. So it gives us additional information about the specific diagnosis, particularly as we look at HER2/neu, at triple negative tumors. We kind of look at those in a different light and deciding maybe we should be more aggressive up front, even talking about giving therapy, chemotherapy up front before we think about doing surgery. What's called a neoadjuvant, before really a definitive procedure's been done, to treat that, to make this smaller, and then talk about doing surgery at a later time. So markers are extremely important. And again, we mentioned earlier there's something called an Oncotype DX study that looks at a recurrence score. So we have a lot of additional information. In addition to that, there's multiple other scores out there. They're currently being vetted to see how they're going to influence how we treat patients in the future. The surgery you're going to have, if you choose to have a lumpectomy, is one where we go in and just take the tumor itself out. The other thing important about the pathology, you're going to hear something is the surgeon's concerned about the margins. How wide around the tumor did he take, and if there was any tumor left behind on any of these margins. That has importance because if one of these margins is positive, you're probably going to have to go back and have a re-excision of that margin. And sometimes if multiple margins are positive, they may have to go back and actually do a mastectomy at that point in time because they want to get all tumor out with no tumor noted at any of the margins. So it's important to do that. In order to do lumpectomy procedures, we always have to add, when we do mastectomies, you have mastectomies alone and then you can have chemotherapy. Lumpectomy procedures require lumpectomy plus a sentinel node plus radiation therapy and then possibly chemotherapy after that. But lumpectomy and radiation therapy are basically married together. They have to be done at the same time. It's not one or the other. And the reason for that is that when we look at all these large trials that we've done, that shows the same overall survival rate and the same local region recurrence rate. So there's not mastectomy, lumpectomy, radiation therapy. There's really no difference. Radiation therapy has changed a lot. It used to be that you would come into the office for 20 to 30 minutes once a day for about 32 treatments, about 6.5 weeks of therapy. About 10 years ago, we started using more of what's called a brachytherapy technique, where we put a little balloon inside the breast. Then we have an after-loading catheter that you will go to the radiation therapy suite. They will put a little seed in the middle of this catheter. It'll dwell for about 10 to 15 minutes twice a day for about 5 days. So 10 total treatments. So Monday 2 treatments, Tuesday, Wednesday, Thursday, Friday 2 treatments. On Friday, your last treatment's done, they pull the catheter out and you're through. So instead of 6.5 weeks of radiation therapy, we've got it down to 5 days. Now, not everyone is eligible for that. You have to have a certain distance between the margin of the skin and the cavity where the tumor was taken out. And if it's below that margin, it's really not the right thing to do for the individual patient. But probably about 20–25% of patients are really eligible to have this technique. The other thing we're starting to do now, which is kind of interesting, is instead of doing it in 5 days, we now can do it at the time of your surgery, called intraoperative radiation therapy, where you come in the hospital that day, and you may be working on Thursday, you have your surgery on Friday, come in on Friday, you have your Sentinel Node done, you have your lumpectomy done, you have the balloon put in while you're in the operating room, you have your radiation therapy done, and you leave as an outpatient that afternoon, and guess what? You're done with your radiation therapy, you're done with your surgery, all in one setting. And so that's where we'd like to go in the future in terms of that. The other thing is that one of our centers in Denver is starting to do is something called laser ablation. So instead of having surgery to remove the tumor, they actually use a laser and just ablate the entire tumor in the margin. A little more experimental, but it's still something that you could come in, not even really have big surgery, and not even know your nodes, and because we have other type of biomarkers that we're looking to see, is this something we're worried about? And then have intraoperative radiation therapy, and now you're through with everything. So the thing is trying to get the line of best fit. I mean, if you have a patient, I want to treat you with the right amount of therapy, but at the same time, the least amount of therapy that's right for your tumor. Clinical trials in breast surgery, again, it's probably the surgeon was involved with the initial clinical trials that led all these randomized multi-center trials to decide if lumpectomy versus mastectomy was an adequate operation. And it really has shown that surgery, when you get them to get involved with that, really does form a role in this. In terms of recently, we're starting to get more things on looking at biomarkers in trials and seeing if biomarkers show certain things. Should certain people really be steered to having, you know, at the time maybe treatment before they have surgery, or surgery, different types of surgery, particularly in the triple negative tumor. It's now being shown that probably lumpectomy radiation therapy may be a better choice because radiation is important. And we now know that mastectomy, also talk about mastectomy never having to have radiation therapy. The problem with that is that if you have 4 or more lymph nodes, generally you're recommended to have radiation therapy after mastectomy. So I think as we learn more about this, we'll be able to try to figure out exactly who's proper for this. So in saying that, what we're looking for is that some of these patients, we're really rolling into trials of neoadjuvant therapy, so chemotherapy before we talk about having surgery at this time.